Good morning, respected faculty and dear delegates. Welcome to our penultimate session of Master E classes in nephrology. I request Dr. Dinesh to please start the session.
Thank you, sir. Thank you. Good morning, everyone. And myself is Dr. Dinesh Goel, Secretary, IIP Delhi. I welcome you on the behalf of IIP Delhi office in this second last session of this mastery classes in pediatric nephrology. And today's topic is congenital abnormalities of kidney and urinary tract. This is a very important topic. We see so many abnormalities or accidentally sometimes like polycystic kidney or some double ureter or many more things which are there. We feel or we encounter in our OPD practices whenever we get an ultrasound report from many patients. So that is why this topic is chosen. So, and I welcome Dr. Sushan Uthup from Kerala. Ma'am is the professor and HOD, Government Medical College, Turunpuram. Dr. Sudha ma'am, the senior consultant at Apollo Chennai, and our president IIP North Delhi, Dr. Satpal Singh Yadav. And I must congratulate Dr. Neha Bandari to conceptualize this Master E classes on pediatric nephrology. Beautiful topic she has chosen. And I welcome Dr. Pankaj Garg also, the past president of IIP Delhi, and everyone. Now, hand over to Dr. Before that, I would like to invite our President, Sir, Dr. Ajay Gupta, sir, to say welcome word and then hand over to Dr. Neha. Thank you, sir.
Thank you, Dr. Dinesh. Today we're going to discuss a very common and important topic of congenital abnormalities in urinary tract, because most of these abnormalities can be picked up in utero also. And many times we get a newborn with the mother showing the report there was some hydronephrosis kind of picture is there. So we sometimes we don't know what to do. So I hope with today's session all these things will be clarified, because nowadays even the intrauterine interventions are possible. And I thank all the delegates who have been diligently joining our webinars on every Sunday. We had a very good attendance, around 300 delegates, and we'll be starting with the hematology session shortly. So I request all of you to please join the pediatric hematology master E classes as soon as we launch it. Thank you so much. I request Dr. Neha to please carry on the session.
Thank you, sir. First of all, a big thanks to IIP Delhi for conducting such a beautiful program, because we get a lot of feedback from all the students who have joined, pediatricians who have joined, and wonderful program. They have been living far away, and they have still learned a lot from this master classes. And as today's topic, this is, I think, one of the very important topic, and it is very important and close to my heart, because if we pick these children early, I think the future of these children really is decisive if they are picked up early, treated early. So I will not be in between the talk, because we have two stalwarts today with us. So I would like to welcome first Dr. Sudha Mehta. So Madam is a senior consultant pediatric nephrologist at Apollo Children's Hospital. She has done multiple publications. She has also been a chair at various committees of IPNA as well as ISPN. And she has also authored pediatric nephrology books. So I would like to welcome Dr. Sudha. Welcome, ma'am. Then I would like to welcome our speaker for today. Madam doesn't need any introduction. Dr. Susan UTHUP, ma'am. She's, I think, much more qualified to be a pediatric nephrologist, because she has already done DM nephrology, DNB nephrology, various fellowships in pediatric nephrology. She's the one who has started DM program at Thiruvananthapuram, Kerala. Madam is the head professor and head of pediatric nephrology department at SAT Hospital, Thiruvananthapuram, Kerala. Madam has also written various test books. She has been chair at various committees at various levels in IPNA as well as ISPN. We would not delay it, ma'am. We really want to hear from you about congenital abnormalities of kidney and urinary tract. Welcome, ma'am.
Thank you, Neha. Shall we start, or Dr. Sudha will be giving some introductory remarks?
Ma'am, we'll start with you. In the end, we'll have remarks from Dr. Sudha.
Okay. Thank you, Dr. Neha, Dr. Ajay, and Dr. Dinesh for giving me this opportunity. And I realize that you have been discussing pediatric nephrology for all the previous weeks, and this is the last but the final session. Okay, so, and this topic is very, very important because congenital anomaly of kidney and urinary tract, which can be picked up in utero these days. And pediatrician is actually coming in contact with such kids for the first time. And there is lot of interventions and this diagnostic modalities that are to be applied by the treating team when we come across congenital anomaly in the kidney. And kidney anomaly is the most common anomaly that is picked up in utero. So in the next 30 minutes, we will be going with this outline of, we will be discussing the spectrum of CACUT, what is the impact of CACUT and the challenges in the management, what are the predictive markers which can tell you what will be the outcome of the child, whether it is a benign anomaly or whether it is a really serious anomaly, and what is the impact of early intervention, early diagnosis, how we can preserve the renal function, how can we prevent the progression, and finally we will have the concluding remarks. So this CACUT, that is a mnemonics, that is congenital anomaly of kidney and urinary tract. It encompasses a clinically broad spectrum of malformations. And these malformations can be involving the kidney or the ureters or the bladder or the urethra. And this is the commonest cause of end-stage kidney disease in children in the initial 2 decades. And 50 to 70% of pediatric kidney replacement therapy worldwide is because of congenital anomaly. And diagnosis is usually prenatally these days, or it can be within first few months of life when the baby will be presenting with some urinary tract infection or other urinary symptoms. Management becomes extremely challenging in infants with bilateral and severe CACUT, and there will be significant renal compromise that can be present at birth. And we all know that when a baby is born with CACUT, there will be a high burden, not only on the family, but on the healthcare system. And when the child progresses and develops kidney failure, it becomes a problem of the society. So actually the epidemiology is really not established or known, but we have got few in this details from the CKID cohort, where in 2015, 689 children were studied, and 76% of children with CKD were having non-glomerular disease, and out of which almost 70% was CACUT. And 25% of obstructive nephropathy, 21% is aplasia, hypoplasia, dysplasia group, and 19% had reflex nephropathy, and 4% other CACUTs. And in the NAPNATICS data, CKD in infancy, almost half of the kids are having CACUT, and ITALKID also endorsed the same fact. And so when we look at the development of kidney and urinary system, starting at the 5th week of intrauterine life, we know that the ureteric bud and the metanephric mesenchyme, they have to come in contact with each other with the red gene on one side and GDNF on the other side, inducing the ureteric bud, inducing the metanephric mesenchyme and producing the kidneys. And the kidney to ureteric bud, the kidney development from the metanephric mesenchyme and the connection with the ureteric bud, if it is not well established, there can be kidney agenesis or kidney hypoplasia, because the ureteric bud, if it is not inducing the metanephric mesenchyme, it failed to develop, or the ascent of the kidney can be compromised, resulting in an ectopic kidney, horseshoe kidney, pancake kidney. So various the anomalies which can be there in the number of the kidney as well as the position of the kidney. And then there can be concomitant urinary tract malformations are there in 50% of the children. And then the abnormalities like the posterior urethral valve in a male child, we know the impact in the long term. So absent or malformed kidney is a severe defect that occurs early in gestation, and the defects that occur later generally will be less severe, causing BUR and problems like that. So we have said the anomaly can be with the kidney, where there can be an abnormal number or position of the kidney. There could be renal agenesis, which can be unilateral or bilateral. Renal hypodysplasia can be with or without extrarenal anomalies, and multicystic dysplastic kidney and cyst in other cystic kidney diseases are also there. But we have to understand that the genetic cystic kidney disease is exactly not CACUT. It is different from CACUT, and it is so CACUT is actually a structural abnormality of the kidney due to developmental problems. Then ureteral anomalies can be PU junction obstruction, megaureter, VUJ obstruction, or PUJ obstruction, then vesicular reflux, and duplex system, which can be there, are all urethral anomalies. The bladder anomalies are severe. It could be very, very severe ectopia vesicae, or when there is a cloaca, the common cloaca is present, it becomes really, really difficult in having the bowel and bladder, which can be rehabilitated and child being given a normal life. It is a really complex anomaly. The neurogenic bladder sphincter dysfunction can be associated with all the spinal dysraphism spectrum of disorders. And there can be sometimes this ureteric sphincter, the urethral sphincter abnormality, and there can be a detrusor sphincter dyssynergia, which will be evolving later. And urethral anomalies, the most common is posterior urethral valve in a male child, or there can be a urethral duplication. It becomes a really complex anomaly, usually associated with the bowel anomalies as well. Then there is severe oligohydramnios Potter sequence that occurs in bilateral renal agenesis, severe posterior urethral valve with renal dysplasia, bilateral cystic dysplastic kidneys, bilateral hypoplasia, dysplasia, or renal agenesis, which can lead to the Potter sequence, which is going to be a fetal ESRD, and the complex problem that is going to be there, and salvaging the child becomes a difficulty. So what are the challenges that we will be facing when we face the Kakut? It can be we have to look at the antenatal determinant, like the genetic makeup of the baby, the maternal environment, the maternal health, the maternal pregnancy associated complications and problems. Then fetal environment is important. And then these are the problems that can cause the renal anomalies. Then kidney anomalies can be, again, that is complicating the nephron endowment, which is decreased because of the renal anomaly. And if the baby is developing an acute kidney injury, that will again compromise and will be affecting the postnatal kidney outcome. And the postnatal kidney outcome, we all know that Kakut is actually chronic kidney disease, because it is the structural abnormality is always persisting beyond 3 months. So all these kids are having CKD. Some may be having a GFR, which is more than 90. We call them as CKD stage 1, but they also require long-term follow-up because of the decreased nephron endowment that may be there initially, that can lead to long-term proteinuria, hypertension, and kidney failure. So to recapitulate the whole things that we have said so far, the epidemiologic information is not precise, and knowledge of the risk of progression and outcome is less robust, and there is geographic ethnic variability. The etiologies, nobody is actually knowing what exactly causes these problems. And there is, we all know that in a country like ours, the KRT, the kidney replacement therapy, is the resource crunch is there, as well as infrastructure and technical problems are there in giving this treatment to children all over the place. And renal transplantation also, children will be having their own special issues. So these are certain common scenarios that we may come across. A neonate with cystic kidneys and creatinine is 1.5 milligram per deciliter at birth. So that is actually the cystic kidney. We mean renal cystic changes in the kidney due to renal dysplasia. Or it could be a 6-month-old baby who is presenting in front of with UTI, and you are diagnosing posterior urethral valve. The creatinine is already 2 milligram per DL. A 10-year-old child with presenting with severe hypertension, and on evaluation is detected to have a progressed kidney disease with CKD stage 4, and we call it as there is a BUR on evaluation, and we say this is reflex dysplasia. This usually happens in a male baby, where the reflex dysplasia and progressive kidney dysfunction in the first decade of life. A 3-year-old girl with ectopia vesicae, even if the bladder is getting rehabilitated by the pediatric surgeon, the outcome of the kidney is again complicated because of the anomaly and the neuronal innervation of the bladder that is abnormal, that can result in upstream problems. Then infant with common cloaca and recurrent pyelonephritis is a really difficult problem. These complicated bladder issues are actually real, this Achilles heel that is there, because management is really difficult. And boy with megaureter, cryptorchidism, and flaccid abdominal wall, this is for the postgraduate students. When you see a child like this, you have to make a diagnosis of prune belly syndrome or eagle Barrett syndrome. And whatever you are seeing from outside is much less than whatever is there inside. So there will be megaureter, megacystis, bilateral hydronephrurethrosis, recurrent UTI, and a chronic kidney disease. So these things we have to really understand and manage properly. And the bad news is that all these children will have progressive kidney dysfunction. So that is an unpleasant truth or a fact that Kakut can progress to end-stage kidney disease. So what are the factors that are involved? There is a congenital reduction in the nephron mass, which overloads the remaining nephrons, and the perinatal stressors. If the baby is born preterm, we know that baby can have a hypoxic ischemic injury or hyperoxia in the newborn period, necrotizing enterocolitis. So all the other complications, apnea of prematurity, low birth weight itself is again complicating the Kakut. So all these perinatal stresses will further contribute to a declining renal function as time passes. And in children with severe dysplasia, there will be end-stage kidney disease in the first years of life, but there will be a phase of stability in these children. That is an initial transient period. The GFR will increase and the baby will start growing. I still remember seeing small babies who are having severe kidney failure in the immediate postnatal period and thinking that they will be on KRT or kidney dialysis soon, but they grow to some extent and infancy they pass. There will be a phase of stability and even early childhood will pass, and because of the hypertrophy of the remaining nephrons, several years may be given, and followed by this phase of stability, what will happen is there will be a progressive loss of renal function that can happen, especially so occurring between in the adolescent and young adulthood, and they will be on dialysis. So when you see 3 kids with posterior urethral valve getting operated today, one of them will require kidney replacement therapy in future. And the risk of progression is almost up to 68 to 70%. So that is the unpleasant truth. But what is the good news? This sort of bad Pakuts which can progress is actually less compared to the small, compared to the less severe forms. And less severe forms are usually in the community with the pediatrician, and they also will have to be followed up properly with the assessment of renal growth, the baby's growth, presence of and calculation of the eGFR. And so a child born with only 1 kidney, the parent will be coming to you in an alarming state of mind and will be asking, what is going to happen to my child? Should I give the child my kidney now? No. A child with a single kidney, if that is a normal kidney, whenever you see a single kidney in a child, what you have to look for is whether there is a compensatory hypertrophy that is there, whether the size of the kidney is bigger than that for the age, and whether the tubes or the ureters are normal, the bladder is normal, there is no other associated abnormality in the kidney and urinary tract. This child can live with his own kidney for his entire life. So that is the good news. So we have to understand, if a child is having 1 normal kidney and other small kidney, and there is no reflex or dysplasia or BUR is not there, that child also, unilateral renal hypodysplasia, they all will live normally the entire life without any problem. But we have to follow them up to assess the renal growth, as well as always advise them not to use the nephrotoxic medications, over-the-counter medications, avoid NSAIDs, and give all the vaccinations. All these are important in that large group of kids who are having a minor renal abnormality. So we have to think about the early diagnosis and early intervention, but how early we should go. So antenatal diagnosis of kidney anomaly is the norm these days because each and every pregnancy gets scanned. So the ultrasonography starting from the 2nd trimester is always from after 12 weeks is going to give you a good idea regarding the kidneys. And by around 16 weeks, the amniotic fluid volume, which is majority of which is contributed by the fetal urine, is going to tell us whether the renal potential is relatively okay. Like if the amniotic fluid volume is good, the kidney is possibly normal and functioning good. Even when there is a dilatation, if the amniotic fluid volume, so that becomes a real good surrogate marker for assessment. And if you see that the amniotic fluid volume is reduced and the kidney, this is actually an ultrasound showing the pelvis dilated and the calyces dilated. And if the amniotic fluid volume is borderline, and if this is a bilateral anomaly, and if there is a keyhole sign, this is a keyhole sign of the bladder, that is telltale for the posterior urethral valve. If that is there, and bilateral kidney involvement is there, brightly echogenic renal parenchyma with cyst, then we can go for the amniotic fluid cytology. You can have the genetic studies also done if there is associated other abnormalities. So a lot of fetal interventions and fetal assessment is possible these days, and let us see further. So early counseling is important. We have to give parental education. And if the amniotic fluid volume is too less these days, there is a scope for prenatal interventions. And if we are not planning that because the baby is actually not that severe, severe problem is not there, then also we have to plan the delivery, because in the early postnatal period itself, we have to start intervention, especially in situations like this, when this is an MCU showing that the bladder is actually trabeculations are there and the posterior urethra is dilated. This is the classic spinning top deformity that you see on MCU in a posterior urethral valve baby, and this baby requires intervention in the immediate newborn period itself. As the pediatrician who is or a neonatologist in the labor room assessing the baby initially should put in a catheter and relieve the obstruction and see that the output is good. And usually these babies, when you put a catheter, they will have a lot of urine coming, and there can be electrolyte imbalance and dehydration that can be there, and those points also should be taken care of. And subsequently, these anomalies, the obstructive anomalies, require intervention in the newborn period itself with the help of the pediatric urologist or pediatric surgeon. So we were talking about the 16 weeks and ultrasonography, assessment of the amniotic fluid volume, amniotic fluid fetal or if bar fetal urine chemistry. Then very, very important is the current UTD classification that we use for the assessment of hydronephrosis in the antenatal period, where we will be looking at the anteroposterior diameter of the renal pelvis, and that will be giving us the UTD classification, which is actually antenatal as well as postnatal evaluation is possible. The antenatal evaluation, if you see that only the epidiameter is increased, that is in the less than 28 weeks, it should be less than 7 millimeters. So anything more than 7 millimeter in the second trimester, and anything more than 10 millimeter, see, the cutoff is actually 4 in the second trimester and 7 in the third trimester, and postnatally it is 10. But if it is actually all 7 below 28 weeks, it becomes really, really significant, and 10 in the beyond 28 weeks, it becomes really significant. But the cutoff is 4 and 7 and 10 in the postnatal period, that we should understand. So anything less than 4 is normal in the second trimester, and anything less than 7 in the third trimester is normal. And in UTD-A1, actually, there is no abnormality in the renal calyceal system, ureters, or bladder, or the renal parenchyma. So that is the importance of this UTD classification, where it is not only the pelvic AP dimensions that are looked at, but we will be looking at the calyceal dilatation, the presence of dilatation that is there in the ureter. Then the bladder is also assessed, and the bladder abnormalities, if it is there, and oligohydramnios and renal parenchymal abnormalities. So if all are S, it becomes UTD A2-3. This is more severe, and such babies require more interventions in the newborn period. And in the postnatal period also, usually, if there is no posterior urethral valve, if the baby is born with a palpable kidney, palpable bladder, dribbling of urine, we will not wait for 48 hours. We will be doing the ultrasound and the MCU in the immediate postnatal period itself. MCU to be done in a sterile system only, as we all know. So if the baby is having urosepsis to begin with, it will be catheterization, antibiotics, sterilize, and then only go ahead with the MCU. And postnatal period, otherwise, if the baby is stable, is passing urine, we will be doing the scan after 48 hours only, because the first 48 hours, the urine volume is less. And then again, the classification, looking at the not only the pelvic APD, but also looking at the parenchyma, the ureter, the bladder, all will be assessed, and we will be making classifications of UTD P1, P2, and P3. And so postnatal follow-up is important in all these babies. And then the next point is how we can predict the outcome. So if we see that there is oligamnios or anhydramnios below 20 weeks, that is a strong predictor of pulmonary hypoplasia and fetal neonatal death. So this is oligohydramnios is defined as the deepest vertical pocket less than 2 centimeters, and anhydramnios has complete absence of amniotic fluid. Then if the amniotic fluid volume is this, you can assess the amniotic fluid fetal chemistry by amniotic fluid aspiration. And if you can see that these parameters, that is sodium is less than 100. So everything less than this, the cutoff is actually associated with a good, this is a fetal good chemistry, whereas sodium more than 100, chloride more than 90, calcium more than 4, beta-2 microglobulin more than 10, total protein more than 20, and osmolality more than 210. That is all indicative of a bad fetal urine chemistry and a postnatal bad fetal outcome. And there is another terminology that is there is the fetal end-stage kidney disease syndrome. That is usually for the babies who are having bilateral renal agenesis or severe hypoplasia or fetal posterior urethral valve with anhydramnios. And in the Western countries, they don't give up on such babies. And I am sure that in India also, at least in some of the centers and some hospitals, we can give whatever treatment that can be given to such babies is possible in our country also these days. And so going further, the impact I have already told you, the fever nephrons that are there, compensatory hypertrophy that is going to be there, hyperfiltration injury that will result in proteinuria, glomerulosclerosis, and there can be an early childhood kidney failure if they severely reduce nephron number. Then associated with that, not only the glomerulus is affected, but also the tubules. So what is the impact of tubular damage? The baby will be a salt wasting, having salt wasting tubulopathy, losing lot of water and salt, chronically dehydrated. And if the baby develops diarrheal disease or some other insult, then again there can be an acute kidney injury on the top of the CKD. And so this baby is not able to concentrate the urine. So the renal concentrating defect is there. So a lot of water is required to excrete the same amount of solute, and that result in chronic volume depletion, and there will be acidosis. We will be coming to that later. Then recurrent urinary tract infection is another problem. They will be coming with the first UTI, but then evaluations are incomplete. Baby is not evaluated, not diagnosed, coming back with the next UTI. So recurrent UTI is again one blow to the repeated blows to the kidney and resulting in renal scarring and episodes of AKI. And then the outcome is going to be like the baby was with the natural evolution. If the baby was going to have an ESKD by 10 years, this baby with recurrent UTI may go for ESKD end-stage kidney disease by 5 years or even before that. And then hypertension and proteinuria we have already said. So this is again in nutshell whatever we have discussed. So there will be volume depletion, there can be hyperfiltration, there will be hypertension, proteinuria, and obstruction, infection, acute kidney injury, acidosis. All this is going to be a problem. And nowadays the approach to all the chronic diseases is a life course approach that can be applied in children with Kakut also. Like we have already dealt with the fetal neonatal issues. And in the adolescent time, what can happen is there can be a rapid kidney growth phase, that is the adolescent growth spurt. And these babies with a reduced renal reserve, they will not be able to sustain that. And that is why most of these babies up till 12 years may be doing reasonably well, especially those with moderate disease. But as they pass through the adolescent growth spurt, they will decompensate because the accelerated progression occurs from the small body with a weight of around 20 kg or 25 kg or 30 kg. When it suddenly becomes 50 kg, the kidney will not be able to hold on, and that will result in the ESKD, end-stage kidney disease, and requirement of dialysis happening at a time when the baby is passing through the child is passing through the adolescent phase. And that is again the adolescent time. All of us know that it is actually a no man's land as far as the clinician is concerned. The pediatrician will be looking after them till 12 years in our country. The adult will be looking after children, adults who are more than 18 years. And so these babies are actually, these children are at a loss. So we have to be more carefully dealing with them, and we have to be doing the diligent follow-up and proper management at each phase. So in the initial phases, there will be failure to thrive. Even when the GFR is above 50% of normal, these babies fail to grow. Why do they fail to grow? Because they are having polyuria, they are chronically dehydrated, salt wasted. They will be having acidosis, electrolyte imbalance, decreased extracellular fluid volume. All these are the problems that a small child is facing in the initial years, even when his GFR is above 50% of the normal. So if you make a diagnosis in the young age, but these babies are usually, we all know that it is congenital, and so they are from birth having the problem. And so if we diagnose the child at a more a later phase, the height deficit will be really, really great because we haven't corrected the acidosis from the beginning. And also we should understand that the growth that is lost during the early childhood will not be gained at any phase in the life. So we have to be looking after them and assessing their fluid status, their electrolyte status, bicarb status, and we should be diligently giving the supportive management so that they will grow with whatever GFR they are having at whatever level of kidney function that is being diagnosed. So how will we preserve the kidney function in Kakut? So there are certain golden rules. That is optimum management of the Kakut. If there is obstruction, you have to relieve the obstruction. If there is a reflux that is there, then we have to discuss with the pediatric surgery team and decide on whether it is just the medical management or the interventions are required. And also we have to assess the upper system by doing nuclear scans and see whether there are already scarring, what is the baseline function, so that those assessment should be done from the beginning. And then prompt treatment of infection should be, and then optimal control of blood pressure. We have to understand that Kakut children can be hypovolemic and hypotensive sometimes, or most often. And sometimes only they can have, if the proteinuria is more, they can have hypertension. So the optimal control of blood pressure doesn't mean that they are all hypertensive. They can be hypo or hypertensive. We have to maintain the blood pressure. So reduce the proteinuria to less than 300 milligram per meter square per day. The acidosis correction is important. In the infancy, we have to keep the bicarb above 20. And for a child beyond 1 year, we have to keep it above 22 for optimum growth. Then correction of anemia and maintain hemoglobin at 11 to 12 gram per DL and maintain the calcium phosphorus in a normal range. And we have to give them vitamin D, but remember that we should be avoiding hypercalcemia. So it is a narrow path that has to be walked. Obesity to be prevented, dyslipidemia to be controlled, nephrotoxins have to be avoided, and AKA episodes have to be avoided. And the periodic assessment of the urinary tract. Sometimes what we see is the posterior urethral valve gets ablated, but subsequent assessment, sometimes you see that the obstruction is still there. It could be because of partial fulguration, or it could be because of the urethral stenosis that is coming up. So we have to see whether the bladder functions are good. Bladder, if it is abnormal going on to be, then the kidney again will have to suffer the back pressure changes and further damage. So the management should be the specialized multifaceted team. Technical expertise is important. Focused strategies are there. It is a team who is managing the child and not the single doctor. And also at each point of time, we have to assess all the points that I have told you already. We have to have a multifaceted approach that is to be there. And antenatal interventions, how far it is beneficial. That is, the Pluto trial has shown that vesicoamniotic shunt placement in 31 patients, but it was underpowered and it was not showing difference in the long-term kidney survival, but there was definitely improvement in the perinatal survival as the pulmonary hypoplasia got ameliorated or improved. So a meta-analysis of 2017, including the Pluto trial. Pluto trial, the number of patients were less, 246 fetuses from 9 large data sets. And they have also found that perinatal survival is better because the pulmonary hypoplasia is better, but there was no difference in the long-term renal survival. And nowadays, this fetal interventions not only is vesicoamniotic shunt placement, it is actually fetal this posterior urethral valve ablation. That also can be done in the intrauterine life. That much we have reached. And vesicoamniotic shunt placement or a vesicostomy or even a posterior urethral valve ablation, these are all antenatal interventions. And these interventions have improved the overall perinatal outcome, but not the long-term renal outcome. So neonatal surgical interventions, we have already said, relief of blocks and leaks, pulmonary support for the respiratory support for pulmonary hypoplasia, metabolic control is very, very important, and putting a catheter, relieving the obstruction may even avoid the need for dialysis in the newborn period. And so we have already discussed all these, and growth during the first years of life is very, very important. We have to pay attention to that. And the recent trend is actually children with Kakut are growing normally thanks to the interventions by the treating team everywhere. They are looking at the correction of fluid management, correction of acidosis, prevention of infections. And so urinary tract infection is prevented. and that also will help in longer renal survival. And they survive even when they are developing end-stage kidney disease. Nowadays, our country, we are able to give kidney replacement therapy for these kids and kidney transplant also. But looking at the primary prevention, we don't know why it happens. So primary prevention becomes relatively difficult in this particular situation. We don't know what exactly causes kaput. But early detection and aggressive management is possible by the multidisciplinary team approach, and we can correct the reversible factors, we can slow the progression, we can treat the complications, we can look at the nutritional status, improve the nutritional status, we can immunize them, and then if children who are really bad to the start with a bad kidney and bad system, you can actually prepare the family for a kidney replacement therapy as the time comes. So all these gadgets which are there now are actually game changers. A baby who is fluid overloaded with posterior urethral valve or bilateral renal agenesis in the newborn ICU, nowadays it is possible to ultrafilter them with aqueducts, and then we can have an automated peritoneal dialysis started in the newborn period itself. We can have a gastrostomy placed. We can feed them. We can give them growth hormone, and by around 1 year, you will see that they are growing normally, and they can be given the transplant. So the story is not that bad. There are solutions that are there, and the best news is that only few percentage of these kids will be requiring, we have to go a long way like this. Most of them with minor anomalies, with attention to prevention of infection, correction of a vesicouretic reflux, correction of some anomaly that is there. I have told you PUV also. 1 in 3 is requiring KRT in future. 2 out of 3 are going to have a normal life with the interventions that we have done in the immediate newborn period. And so the risk factors for rapid progression are the obstruction that is not relieved, infection that is there, volume depletion, AKI episodes, malnutrition, uncontrolled hypertension, proteinuria, and these nephrotoxic drugs. We usually come across kids with UTI getting aminoglycosides, children with kakut getting and volume depleted getting ACARB, then use of NSAIDs, contrast agents, and also we have seen children with congenital heart disease and cardiac failure on furosemide, receiving ACE or ARB, and on the top of that developing some infection and getting aminoglycoside. So killing the kidney with drugs is something that we have to prevent, and we have to be alerting our treating team wherever they are. And so children with kakut will fail to grow. So we have to optimize their growth by adequate nutrition, correction of fluid electrolytes, correction of acidosis, and treatment of renal osteodystrophy. Now the terminology that is used is mineral bone disorder. And then after optimizing all these anemia, inflammation, we can even think of giving the growth hormone for them. So optimizing growth, giving growth hormone. After correcting all these factors, nutrition is the most important factor. Management of nutrition is the most important. That is the pillar for optimizing the growth. And without nutrition, the growth hormone is also not going to be effective. And acidosis, MBD, and anemia also need to be corrected. So attention to nutrition. So nutrition is most important in maintaining them growing. And we have to see, the people will be asking us, what is the caloric requirement? What is the protein requirement? And so high biological value protein is important. So high biological value protein, the biological value acid is very high, 100% if that is there. The azotemic waste is actually not there. And so that helps in having the child grow at the same time not having uremia. So these are important. So protein requirement and caloric requirement should be addressed to. And even when they are progressing through stages of CKD, you can see that 100% of the dietary recommended intake for the ideal weight is required for the protein. And if once you start dialysis, more protein is required. And always give attention to vitamins and trace elements. And in children with CKD and children with kakut and hypertension, proteinuria, the independent risk factors for progression. But remember the news that the hypertension is less common in a fluid depleting phase kakut. And what about this salt and fluid? So we have to have free water access. and sodium supplements, because these children are actually salt losers. But at the same time, if you see that the blood pressure is high and the urine output is dwindling, at that point of time, you have to restrict the salt and also control the hypertension. And bicarbonate therapy becomes a pillar, not only for correcting the acidosis and optimizing the growth, but also for preventing the progression of chronic kidney disease. And so we are in an era where we know that obesity is alarmingly there in our population, in kids also. So maintaining a healthy diet and ensuring optimum physical activity, preventing dyslipidemia is also important in all children, and especially so in children with a compromised kidney and urinary system. And so that growth and puberty, always remember that as puberty comes, there will be accelerated progression of kidney damage, because kidney function starts declining, because the kidney is not able to hold on to the body mass increment. The renal reserve is compromised in these children, and so we have to be paying attention. All vaccinations as per the immunization protocol and live vaccines all should be given prior to transplant. Annual killed influenza vaccine is important, pneumococcal vaccine as per the protocol. Hepatitis B vaccine, in the early phases when the GFR is good, you need to give only the regular dose. But if the child is picked up at a later time, you might have to give the double dose and check the antibody titers. So we look forward to a time. This is a baby with prune belly syndrome. I have this flaccid abdomen and bilaterally undescended testes and all. And this baby outside is like this, but inside there will be megaureter, megacystis, and a dilated system of the kidney, and will require evaluation. So improved and increased survival to adulthood with preservation of renal function, maintenance of metabolic stability, normal growth and development, reduction in the CVD mortality. We have to understand that all children, all adults, everybody with chronic kidney disease, the most important morbidity mortality point is CVD. And dyslipidemia, that is going to be there. The dyslipidemia, that is going to be there. So it is an atherosclerotic milieu that is going to be there. So obesity and all those points which I have already discussed, we have to think about. So, but we have to understand the pathogenesis. Pathogenesis is yet not clear. We know only the tip of the iceberg, or tip of the knowledge that we know is only the tip of whatever is there. New strategies aimed at early intervention needs to be developed, and a lot of research is going on. A lot of new molecules in pipeline for arresting the progression, antenatal genetic diagnosis, in utero surgical techniques, whether we intervene early, more early, then red genes and development, then targeted therapy to prevent renal fibrosis. These are all we want, and possibly in the future we may come across. So Kakut is a dynamic and complex medical surgical problem. Early diagnosis and early intervention is going to optimize the outcome, and the minor and the mild and the intermediate forms, it is those kids are in the hands of pediatrician to prevent UTI episodes, intervene early to relieve the obstruction, and follow them up diligently to avoid further UTI episodes and avoid nephrotoxic medications, optimizing their growth, preventing their progression. And finally, once they are this, you feel that the progression is happening, you have to give them to the pediatric nephrology team for further management in time. Thank you.
Thank you, ma'am, for such a talk. I think we covered everything possible in Kakut. I would request Dr. Sudha. Ma'am, are you there?
Yeah, I'm there, Neha. Am I audible?
Yes, yes, yes. So
Okay,
we would
yeah.
like to hear some expert comments from you also.
Yeah. So first of all, I'd like to thank Neha, Dr. Ajay, and Dr. Dinesh for organizing such a wonderful session in pediatric nephrology and giving me the opportunity to moderate Dr. Susan's talk. And I think ma'am's talk has been excellent and engaging as usual. And so what today's session has actually highlighted is that CACUT is not a single disease, but it's actually a diverse spectrum of congenital disorders, each with unique challenges and outcomes. So, and again, Dr. Susan's talk has reminded us that timely detection is very, very important, and also we need to appropriately evaluate postnatally, and we need to identify children who require surgical intervention and treat them appropriately, and risk stratification are fundamental to optimizing long-term kidney health. And also what we need to understand is that not every child with CACUT is going to progress to end-stage kidney disease, and we need to individualize their treatment. And it is very important for early recognition and the modifiable risk factors, which ma'am has actually highlighted, that is recurrent urinary tract infections, the bladder dysfunction, hypertension, proteinuria, urinary tract obstructions. So all this will significantly, it will influence the long-term outcomes. So it is very important that these children have a lifelong follow-up, as the kidney functions actually may decline gradually over many years, and many of them get into trouble during the adolescence. Sometimes who are missed in the earlier stages, they get into trouble during adolescence, and because these children may actually appear to be very stable during the initial period. So it is very important that the successful management requires a multidisciplinary approach, which involves the pediatric nephrologist, urologist, pediatrician, radiologist, obstetrician, geneticist, and definitely the family members. So this is what, in summary, for the CACUT. And one more important thing is, like, especially children who have single kidney disease, we also have to probably educate the parents that obesity is something which should be avoided, because these kind of children, where they put on a lot of weight and then they get into trouble with the hypertension and proteinuria coming at an earlier age, and that is again going to lead them to sometimes it can lead to CKD. So obesity also we need to keep in mind when we are treating the CACUTs. So there are some questions. Suppose CACUT is diagnosed antenatally at optimum time, and there is likelihood that the baby may need a transplant at a later date. Is this a part of the informed decision for termination of pregnancy? So now, for termination of pregnancy, sometimes we do not know exactly what is actually happening. But once their liquor is reduced, and we know that this child is having a single kidney, and if that single kidney is again not functioning, and at times if the PUV is very severe, and we have diagnosed this at the right time, that is before 24 weeks, only then we can say that we need to terminate. But at times, not always we know that this child is going to end up in a transplant. Sometimes we may not predict it appropriately. So only if there are certain set of markers, like the oligohydramnios, or both the kidneys having hyperplasia, smaller kidneys with dysplasias, and ureterohydronephrosis, and if the PUV is quite significant. Susan ma'am, what is your comment on this?
Exactly. If there is almost severe oligoamnios and hydramnios, brightly echogenic cystic dysplasia that is there in the kidney, all these diagnosed before 24 weeks, you have to give them an informed information about everything, for them to take an informed decision on whether to go ahead. But since the kidney functions can be replaced, usually an isolated kidney defect, even at this severe form, is not becoming a medical indication as such. But the parents should be informed that such a child with such a severe abnormality is going to mostly require a kidney transplant in future, and so that also should be taken into consideration when they are taking the final decision. So that is, again, that question is very, very relevant. And if the anomaly is not a severe form, we know that the longevity is not going to be affected, and the dialysis requirement is not going to be there, as whatever information is possible is available at that point of time. Then possibly we will be telling them like that, but you never know, because whatever we understand from whatever information we have as of now is possibly not enough. Like, we may think that this child is going to require KRT in the first decade, we may make an assessment, but the child may not require a KRT even in the adolescence and in the young adulthood. if we are optimizing the further investigations, evaluation, management, and follow-up, if we do it properly, the child may not require at any of these points. So you cannot say that by first year the child will be in ESTD. You can't say like that. And I still remember some anecdotal. A baby was born with severe oligohydramnios. The baby was born, and then the pediatric surgeon was looking at the baby, very small, tiny, puny, less than 1 kg. They were not having the scope to do the posterior urethral valve ablation also, and they did a bilateral ureterostomy, and then said that there is no point in thinking about it because this baby may not survive till 1 year. But the baby was living even at 8 years. 9 years. Only thing is severe renal compromise, but not on dialysis, growth failure. All those problems are there. So you cannot really tell when a child and what is his kidney status just by looking at what we have as of now as the information.
Thank you, ma'am. I think all the questions have been answered, and it was a wonderful talk from both of you. And Susan, ma'am, absolutely stunning talk. I would now hand over the mic to Dr. Ajay, sir. Are you there? Dr. Dinesh?
Dr. Dinesh, unmute yourself.
Yes, ma'am. Yes. Thank you, Dr. Sudan. And it's a wonderful talk, and many clarities are done. And antenatal to postnatal diagnosis, assessment, and the current treatment is mainly required so that a good productive life can be achieved. So, thank you, Dr. Neha, for wonderful conceptualization of this 3 modules. Thank you, Dr. Sudan. Thank you, our chairpersons, Dr. Sudha and Dr. Satpal. Now, I welcome our treasurer cum secretary like Dr. Ravinder sir to say formally a vote of thanks in this session. Over to you, sir.
Thank you, Dr. Dinesh. Thanks again, Dr. Neha. Thank you, Sushan ma'am, for a very crisp talk and expert input by Dr. Sudha. I think as we pediatrician and most of us which are dealing with the neonates, these congenital abnormality, we face so many times much dilemma. Thank you for clearing all doubts. And I think it's a nice topic which I think Dr. Neha is very rightly thought it should be also discussed. Thank you.
Thank you, sir.
Have you a good day. Bye. Thank you.
Bye.
Yeah.
Thank you. Bye.
Thank you all. Thank you.